So hi everyone, my name is Tayler Buchan. I'm a current PhD student in the HRM program, working under the supervision of Dr. Gordon Guyot, as well as Dr. Carolina Alba. So this afternoon I'll be presenting some preliminary data from my PhD thesis project. Heart failure is a critical medical issue with a rising prevalence of over 700,000 Canadian adults and 50,000 new diagnoses per year. Mortality among heart failure patients is very high, nearly 6 times higher than patients with other chronic diseases. To prevent further decline, improve quality of life and survival, advanced heart failure patients are considered for advanced therapies, namely ventricular assist device or heart transplantation. Given the increasing global prevalence of heart failure, as well as the aging population, an increasing number of patients require these advanced therapies. These therapies are, however, costly and associated with serious risks and complications. Therefore, it is critical to select patients who will realize the greatest survival benefit and intervene at the optimal time. Given the clinical complexity of these patients, evaluating prognosis for advanced heart failure patients is challenging. During the evaluation process, heart failure patients undergo a series of medical and psychosocial assessments that inform their estimated survival prognosis. These prognosis assessments, placed in the context of guideline recommendations, are what ultimately determine the decisions of whether patients require and could benefit from advanced heart failure interventions. Currently, medical decisions on the appropriateness and timing of advanced heart failure interventions relies on the informed judgment of a multidisciplinary medical care team. Previous work, however, highlights the shortcomings of physicians for evaluating the need for advanced therapies or predicting mortality among patients with advanced heart failure, with overestimation of risk commonly observed. Risk prediction models integrating many clinical variables may offer valuable support to physicians. These models, however, have not all been developed for advanced heart failure patients, and their prognostic utility in this subset of heart failure patients is limited. As a result, there is uncertainty as to which risk model would perform best in this patient population. So in light of these findings, we've conducted a pilot project to evaluate the prognostic accuracy of risk models in a small sample of ambulatory advanced heart failure patients who underwent assessment for advanced heart failure therapies, and the relationship between prognosis and the clinical decisions made at the end of the assessment. This retrospective cohort study included 332 ambulatory advanced heart failure patients undergoing assessment for advanced heart failure therapies at the University Health Network in Toronto. We collected information obtained during the assessment for advanced heart failure therapies and calculated the predicted 1-year mortality risk using the heart failure metascore. So the heart failure metascore is a risk prediction model that consists of 16 variables, including age, sex, race, ischemic cardiomyopathy, previous heart failure admissions, among others, to predict the risk of mortality among patients with heart failure. We also collected the medical decisions that were made by the multidisciplinary care team for each patient at the end of their evaluation for advanced heart failure therapies. We classified these decisions into 3 groups. The first for patients who were considered candidates for advanced therapies, which included patients who were listed for heart transplant or provided a date for VAD implantation. The second for patients who were considered too early for advanced therapies, such as those whose clinical status improved on medical therapy. And the third for patients who were considered too sick for advanced therapies. This last group includes patients who had medical contraindications, psychosocial contraindications, reluctance towards advanced therapies, among other reasons that rendered them inappropriate candidates for advanced heart failure therapies. This group also included patients who died during their assessment for advanced therapies. We also collected each patient's mortality status following the start of their assessment. Of the 332 patients included in this study, 175 or 53% were deemed candidates for advanced heart failure therapies. In the 84 patients deemed too early and the 73 deemed too sick, so those patients who did not undergo advanced heart failure interventions, we assessed the heart failure metascore discrimination using the C statistic and calibration by the observed versus predicted risk using Cox proportional hazard models. We also reported the proportion of patients in different decision groups across predicted risk quantiles. Before moving into the results, I'm just going to quickly go over two terms that are important to understand for interpreting the upcoming results. These are the discrimination and calibration of a risk model, which together reflect how well a particular model generates an accurate prognostic estimate. Model discrimination refers to how well the risk model differentiates individuals at a higher risk of having an event from those at a lower risk of having the event. Measures of model discrimination are typically reported using the C statistic, where a value of 0.5 is equivalent to chance or flipping a coin, while a C statistic of 1 reflects a perfect ability of categorizing individuals. Typically, we consider a C statistic between 0.7 and 0.8 as being adequate. The second measure, which is critical for evaluating model performance, is its calibration. Calibration informs how similar the predicted absolute risk is to the true observed risk for patients classified in different risk strata. In other words, calibration reflects the extent to which a model correctly estimates the absolute risk. Some models may perform well in low-risk patients, but overestimate risk in individuals with higher risk, or vice versa. So in the calibration plot shown here, we can see that the model predicted one-year mortality, indicated by the yellow line, is very similar to the observed mortality for the low-risk patients, but the model starts to underestimate mortality in patients with a predicted mortality greater than about 30%. This is important to consider, as patients with the model predicted mortality risk of 30% may in fact have an actual mortality of closer to 40 or 50%, which would have important implications in the decision-making process. For example, choosing whether or not to defer heart transplantation. For a risk model to be considered as useful, it should have adequate discrimination and calibration. So the heart failure metascore discrimination was adequate in our cohort with a C statistic of 0.72. In figure A here, we have the observed one-year mortality plotted in red, and the heart failure metascore predicted one-year mortality plotted in green for each risk category. So in the low-risk patients, with a one-year observed mortality of about 4%, calibration was excellent. In moderate risk patients, where one-year mortality ranged from 8 to 28%, the heart failure metascore overestimated risk by 6%. And in high-risk patients, where the observed mortality was about 50%, the heart failure metascore overestimated risk by 18%. Figure B, to the right of the slide, illustrates the proportion of patients across medical decision groups for each risk category. We observed some patients in each risk category who were deemed candidates for advanced heart failure therapies, as indicated by the purple bars. So 40% of low-risk patients and 64% of high-risk patients were deemed suitable for advanced therapies and were either listed for transplant or provided a date for VAD implantation. On the other hand, 16% of low-risk patients were deemed too sick, and 10 to 15% of high-risk patients were deemed too well. So these data demonstrate inaccuracies in clinician assessment of prognosis and possible improvements in care through the use of predicted model-guided decision-making. The current study is limited by its small sample size, as we're only able to include 332 ambulatory advanced heart failure patients, and as well as the fact that we only evaluated one of the currently available prognostic models. So as part of my next steps with this project, we are conducting a single center retrospective cohort study of about 2,000 adult advanced heart failure patients undergoing assessment for advanced heart failure therapies at the University Health Network. This study includes a broader range of patients, as 60% of patients in this cohort were ambulatory at the time of evaluation, while 40% were admitted to hospital during their evaluation for advanced therapies. We are currently in the process of collecting approximately 150 variables from the medical and psychosocial assessments conducted during the evaluation for advanced therapies for each patient. These variables will encompass a wide range of information collected at the time of evaluation, including patient demographics, comorbidities, parameters from physical exams, lab values, and data points from ECGs, echoes, right heart catheterization, abdominal ultrasounds, among other tests. Included in this list are the variables required by 6 risk scores, 4 of which will be used to predict mortality among ambulatory patients, and the other 2 among inpatients. We will test the performance of each of these existing risk models in our cohort to identify the best model for predicting mortality risk among advanced heart failure patients. We are also planning to develop and validate a novel risk model using a larger scope of clinical data and compare its predictive performance to existing models. So in addition to demonstrating study feasibility, these preliminary results reveal that formal prediction models have promising accuracy for patients with advanced heart failure. In contrast, heart failure cardiologists consistently overestimated risk, potentially exposing patients early to advanced heart failure therapies. After assessment for advanced therapies, an important proportion of low-risk patients underwent heart transplant or VAD implantation that was likely premature. Given the findings from this study, it is important to test these findings in a larger sample of advanced heart failure patients, including those admitted to hospital, and determine if other existing risk models, including those derived from general heart failure populations, such as the Seattle Heart Failure Model or the MAGIC score, or a new model developed among advanced heart failure patients, performs better than the heart failure metascore. Thank you, and I'll take any questions you might have.